So the consequences of untreated and ineffectively treated mental health disorders among youth are likely to be significant. Mental health disorder prevalence rates for youth are at least as high as those for adults. Indeed, half of all lifetime adult mental health disorders have an onset during childhood, and many disorders reoccur over the lifespan. Given the demonstrated efficacy of hundreds of psychosocial interventions, impairment related to mental health disorders could be markedly decreased with greater utilization of these interventions in communities. Greater utilization can be enhanced by early detection and increased access. A study published by Dr. Maggie Alegria and colleagues in the Journal of Health Services Research cautioned, however, that increased access to services as a result of the expansion of insurance coverage through the Affordable Care Act may actually result in decreased use of behavioral health services for some ethnic, minority, and racial groups. Their research found that expansion of insurance coverage could increase access for Latino and non-Latino whites, but have modest effects for African Americans. Partial explanations for this difference include the lack of provider supply, patient preferences for care, and sociocultural factors like stigma and other perceptual barriers. While the work of Alegria and colleagues largely pertains to adults, these adults are likely to be the caregivers of youth with mental health needs, caregivers who access services on behalf of their children. The fact remains that the largest proportions of youth with mental health needs are not likely to receive treatment for those needs. It is clear then that it will take more than just creating better access to improve mental health service utilization among children and their families. So with these thoughts as the backdrop, this very esteemed panel of experts will share their wisdom about their efforts to inform the public about the need for early detection and treatment of mental health problems. This conversation should stimulate important perspectives regarding who best to target in our efforts to improve early detection through both policy initiatives and community practice. The implications for early detection and treatment efforts on service coordination, especially regarding the ability to provide care once need has been documented, and the utility of social marketing campaigns. For example, what are the key messages? What is the appropriate medium for these messages, and who are the appropriate targets? Recent tragedies in terms of mass violence and school shootings painfully remind us that untreated and undertreated mental health problems may underlie the behaviors of the perpetrators. We cannot afford to miss, in the search for answers to these tragedies, the importance of early detection and treatment of mental health disorders. Certainly having a mental health disorder does not lead one to be violent. In fact, what we know from research on early psychosis is that 1 in 5 who experience early psychosis commit suicide, thus violence turned inward. Generally, those who experience mental health disorders may have more violence directed at them. For these reasons, this discussion on early detection and treatment is key and fundamental to any change efforts. And our experts are here today to offer their insights. So first we will hear from Dr. Sherry Molock, an associate professor of psychology at George Washington University right here in DC. Dr. Molock's research is on the front lines of early detection and treatment. Her research focuses on depression and suicide among African American adolescents, and she has also developed suicide prevention programs in African American churches. She will talk to us about her research and practice work involving the faith community in early detection and treatment efforts in child mental health. Next, we will hear from Linda Rosenberg. Linda is president and CEO of the National Council of Behavioral Health. Under her leadership, the National Council has helped to secure the passage of the Federal Mental Health Addiction and Parity Law, and has played a critical role in ensuring the Affordable Care Act addresses the needs of individuals with behavioral health disorders, including expanding financing for integrated behavioral health and primary care services. Linda will talk with us today about her organization's policy and practice agenda, including 3 pieces of legislation with bipartisan support now in Congress addressing early detection, treatment capacity, and service coordination. She will also discuss legislation the organization is currently working on focused on first episode psychosis. Finally, Lisa Rubenstein, a project officer for the Child, Adolescent, and Family Branch at the Center for Mental Health Services at SAMHSA, will be our final speaker. Lisa has over 25 years of experience conducting social marketing campaigns. She has been at SAMHSA since 2001, where she is responsible for the Caring for Every Child's Mental Health campaign, a social marketing campaign addressing the importance of children's mental health. Lisa will talk to us about her role at SAMHSA and other current initiatives in which she is involved regarding early detection and treatment of mental health problems among children and families. The panelists will have about 10 to 12 minutes to make comments. After each presentation, I will ask 1 or 2 questions. After we hear from Lisa, I will ask a question or 2, and then we will open up the floor to the audience for questions. Again, it's indeed a pleasure and a great honor for me to moderate this panel with such esteemed colleagues. As I shared with them in correspondence prior to this panel today, I've admired their work for many years. I'm sure you will find their comments to be both insightful and inspiring. So now we will hear from Dr. Sherry Molock.
Okay. Good afternoon. So I want to thank Dr. Lindsay for that nice overview and those introductions. I want to thank Dr. Charles Lewis for inviting me to come here today. And I'm going to just spend a couple of minutes talking with you about my work, particularly in faith-based communities. And so as Dr. Lindsay noted, we do know that the prevalence of mental health disorders in children is rampant and, in my opinion, unacceptable. We also know that most children, but particularly children who live in communities of color, tend to be underserved for a variety of reasons, and some of that is cultural, with barriers and stigma, but also some of that has to do with access issues. And so what I want to do today is talk with you just for a few minutes about considering partnering with faith-based communities. I do want to stress that my context will be a Christian church because that's my background, and also in addition to my work in psychology, my husband and I co-pastor a church in Prince George's County, so we actually put into practice some of the things I'm going to be talking with you about today. So the reason that I think it's important to you to consider developing partnerships, and my area of expertise is with African American churches, is first of all, African Americans attend church and religious services and engage in private devotional practices more than any other ethnic group. And so if you count church practices or faith practices, including private devotional and or attending church at least once a month, and about 80% of African Americans attend church or have some kind of affiliation. And so that's an astronomical, in my opinion, opportunity to connect to people in ways that you might not otherwise be able to do so. The Black church has a strong history of helping in the community anyway, and we do know that ethnic minority communities in particular, but also African Americans, are actually more likely to go to their clergy person to get mental health services or help, not services, but help, and they tend to prefer those services or that help when they go there first. So I became interested in this area primarily because I realized that it was much easier for people to go to their clergy than it was to come see me, and I wanted to know why that was. We also know that religion can be very protective against mental health concerns of all kinds, which include with youth, substance abuse, delinquent behavior, unplanned teenage pregnancy, HIV infection, other health concerns, depression and suicide, and substance and tobacco use. And so the neat thing that I think about churches is that parents will take their children to church even if they're not a member of that church. And churches love for children to come, and so membership is not required for your child to basically benefit from the services and the programs that are provided in a church community. Churches are very affirming of children. In our church, Thursday, we're having Hallelujah Night as an alternative for children to go trick-or-treating, and so they're going to have a costume contest. Every child will win something no matter how old they are. We have toddlers up to teenagers coming, and we have a lot of housing developments near the church that we pastor, and so we get a lot of opportunities to really to deal with youth around a lot of different kinds of mental health concerns. And it's a safe place for them to go. It's a place that parents feel comfortable. The other thing, and people often ask me about, well, why can't we do these interventions in schools? We can, but one of the differences between a church and a school is that a church has no evaluative component whatsoever. We don't do report cards there. We don't have parent-teacher conferences there. We have great office hours. We're basically open 24/7. You can call us morning, noon, and night, and people do that. And there's no tension there, because some of the parents that we work with really feel that their children are unfairly labeled, and or they're not comfortable with their children receiving a mental health diagnosis, which may carry over in their records. And there's some reality to that, and their children being stigmatized or tracked inappropriately. And in church, we have children with autism spectrum disorder. And in fact, one of the members whose children experiences that, the reason why he's in our church is because we let his child participate. We're the first church that he's belonged to where we let his child actively participate in the programs with the children. So that child is well integrated into everything that we do. It was also an opportunity for us to talk about autism spectrum disorder as a congregation. We have families with members who have serious mental illnesses, bipolar disorder, schizophrenia. So it's also a way for us to be a resource to them. So those are things that are done in a very non-judgmental and non-stigmatizing environment. So that's, I think, a big plus for us. The biggest reason why I really promote this in my research, church is a great place to change norms about mental health seeking behavior. And so the way that we do that, and the way that my programs try to teach churches about this, is we integrate mental health messages and proactive mental health seeking in every facet of our services. So it's in Bible study, it's in Sunday school, it's in literature that we provide, it's in the bathroom, it's in the stalls, so that if you don't feel comfortable picking up literature from a table, you can get it from the bathroom. Sometimes we work with House of Ruth. House of Ruth has some really neat ideas for how to do domestic violence or intimate partner violence prevention, and one of those is to put safety plans inside of lipstick tubes. And so women can take those out of the bathrooms, or they're on emery boards, and just take those and put those in their pocket. And it also keeps women safe because the plan is inside a tube in case their partner sees the plan. We have health fairs, we have community health fairs, we have exercise programs, we have Get Fit for Jesus. And even myself and my husband, we're in our mid-50s, we get down and do crunches and stuff. We have professional fitness trainers, we do that. So we have lots and lots of different things that we can do. But also, I think that one of the most powerful ways we do that is we actually embed help-seeking messages within sermons, because that's a great time. We have everyone there. We tend to focus a lot on suicide, depression, and actually bipolar disorder, because some of the major prophets have some of those illnesses, and you can point those out within the context of a scripture. You can even do a clinical trial. There's actually a scripture about a clinical trial. So for those of us from the olden days of split plot designs, there's a split plot design in the Bible. So you can use that if you want to, and that's really old. People don't do those anymore. Now, there are barriers to doing this, because clearly there are mental health the mental health community, for the most part, is not trained to work with faith-based communities. And also, faith-based communities sometimes are skeptical about working with mental health professionals, and they're also skeptical about working with the government. We've learned this more recently, particularly as you have more people who may be undocumented in this country, that if you, even when we say, you know, this is it's a brochure from SAMHSA, and we say this has nothing to do with your status, people feel uncomfortable with that, and so sometimes you have to figure out ways to work around that and help people feel more comfortable with that. Basically, the clergy persons that we work with are actually very open to doing mental health interventions in churches. Their biggest issue is they feel that they're not respected as a team member, and they're not valued, or mental health professionals and researchers come from outside the community and tell the community what they need, which makes them feel disrespected. So my suggestion oftentimes is to do a lot of things that you would normally do in community-based research or community participatory research, which is basically to go in from the beginning as a partner, asking the church what they need. In our suicide prevention programs, we actually don't focus per se on suicide. What we focus on are the risk factors associated with suicide. One, it's easier for churches to focus on that because suicide is a relatively rare behavior, and so a church may experience a suicide once every few years. On the other hand, they're very, very aware of people in the church who are depressed. They're very aware of marriages that are stressed. They're very aware of children who are stressed in schools, and they're very interested in intimate partner violence issues. So we focus our interventions around those, and substance use. So we focus our interventions around those, which are also risk factors for suicide. So that works out really well. We make surveying a normal part of our congregation. We don't just survey around mental health, we survey around other things too. So about once a month, the congregation expects a survey. They're very short. They can't be long. And they tend to be, you need to leave some space for open-ended questions, which we do qualitative research for, so for my purposes, that's fine. But because people don't like filling in those little dots, and they really feel you don't really want to know what they wanted to tell you when you don't allow people to sort of put things in their own voice. There's also lots and lots of things that you can do to involve the community, and some of that's just simply neighborhood watches. To get people more involved with that. You can do rites of passage programs for kids. You can have Boys and Girl Scout programs. You can have athletic programs. You can have the Hallelujah Night, which we're doing, and that's spearheaded by young adults. So we have a surrogate grandparenting program that we're about to implement to help children with their reading, because we have a lot of retirees in the community who don't have anything else to do and they love children. And so you can ask them to come up and volunteer. So one of the neatest things about church is people, that's a norm to volunteer. So you don't have to pay people. They don't want you to pay them. And you get people to commit to certain projects, and people are very interested in doing that. So I've been doing these programs for probably close to 15 years in different forms. One of the other neat things that we do every year is a family retreat, where we have programs from all ages, from toddlers up to seniors, and you can do things about grieving, you can do things around intimate partner violence, you can do things about wills and estates, and you combine the mental health with the other things that you're already doing. One of the most successful programs that we did was grieving for widows, and they ended up starting their own support group around that. So there's lots and lots of things that you can do. So I think the bottom line for me is that we need to stop behaving like we live in silos, because we don't. And we need to stop compartmentalizing our lives and our services, because that's not the lives that people live. And that we need to be respectful that we're all members of a team, that we all have something to offer, and that the bottom line is that all of us want people to be whole people, and we have different ways that we can contribute to that. Thank you.
So, Sherry, I just have one quick question before we move on to Linda. What do you see as the biggest barrier to working with clergy and faith communities in terms of the early detection efforts?
Probably the biggest barrier, I think, is that is probably knowledge. So I think that, and I was in another panel yesterday around the same thing, and so a lot of the parents and also the clergy are very reluctant and reticent to label children inappropriately. Lots of concerns about children being over-medicated. So when children are exhibiting behavioral problems at church, or parents come in complaining about that, there's a lot of concern, are we pathologizing children and not allowing children to be children? Then the other issue that we have to be sensitive to is that some of the clergy and or parents probably have had mental health histories in their own families, and there's a tendency to normalize those symptoms. And so how do we help families and clergy recognize when is it something that's problematic and clinical, and that's something we need to intervene at, and when is it maybe just a developmental lag or something that kids are just going through, and helping people understand what the difference is. One of the things I said at the conference yesterday was, if we could just get people to refer or have helpers in the church, because one of the things I said to the teacher yesterday was, it's not really your job to diagnose, that's my job, but what I need you to know is recognize some basic problem areas so that you will know to call me so that I can help you with that.
First of all, following Dr. Molock, is that how you pronounce it, is not easy. Maybe want to join your church for sure. Such a normalized environment doing such wonderful things. So I just want to thank really Dr. Lewis and Dr. Lindsay for allowing me to be with you today. Children is not my area of specialty. I have worked in the area of mental health for 40 years, but primarily with adults with serious mental illness, or people in their teens and early 20s developing early symptoms of schizophrenia, serious bipolar disorder. But what I think I do know about is how to move an agenda, whether it's within an organization or it's here on the Hill. So I'm going to focus a little bit on that. I'm, have the honor really of running an association called the National Council for Behavioral Health, and we have about 2,100 member organizations that employ about 750,000 million staff, serve about 8 million adults and children every year. The primary professional group in those member organizations are social workers. And I, of course, am also a social worker, as are a number of my staff. So what our members focus on really are adults and children who kind of fall into this area of being both socially vulnerable and clinically vulnerable, right? And I think that's what you've been talking about today. One of the things we know, though, is services, when delivered correctly, based upon the evidence, are quite effective. And I think this slide really displays the effectiveness of treatment for serious mental illnesses and other chronic illnesses. I think what we forget, and sometimes we certainly hear on the Hill, is why should we invest in mental health or substance use disorder treatment? You don't really have proof of good outcomes. Well, neither does asthma or diabetes or cancer or heart disease. It's really discrimination in some ways. Diseases people don't all get cured, and they don't all recover at the same pace. And so I think we have to push back on when we get that as a question. Our data is as good, if not better, as we can see here, than other chronic illnesses. I think the other thing is we have a great moment in history. If we can get that website fixed, right? And actually, I had some of my young staff try to get on it just the other day, and it was not a pretty picture. So we all have to keep our fingers crossed, but we have a lot of pieces in play that is going to make mental health and addiction certainly the coverage for those services available to almost everyone. Because even in states that are not expanding Medicaid right now, they will do so. The Republicans in those states need political cover. They have to have a reason for doing it, but no one can resist federal dollars. Philosophically, when they're running for office, they're against it, but once they're elected, they very much like to get it. And so we will see that happen. So we have this coverage expansion, we have parity, which was mentioned before. All insurance has to treat mental illnesses and addictions as they do any other disorder. And we have this service and payment redesign that's moving us towards population health, responsibility for communities, for the people in those communities, and for coordinating care between all the entities that are involved with people who have high needs. But we have a lot of work to do. One of the statistics that I think about, because when you talk about children with serious emotional disturbance, you're looking often towards outcomes that include time in jails and prisons, unemployment. I was just talking to Mary McKay before about how graduation from school, if we do nothing else, if we treat nothing else, if we can get people an education, you're better off being depressed with an education than without one. Other things can come. So one of the things we know is that for people who need substance use treatment, only 10% get it. As compared to those who need diabetes treatment, 84% get it. We know that since AIDS, 600,000 people have died since 1980. 3.3 million have died of substance use disorders. And we know right now most mental health treatment is done in primary care. It's medication, no real measurement of baseline or how people are doing, just writing of scripts, which sometimes get filled, sometimes don't get filled. We really don't have much treatment capacity, and I'm going to get to that. And most Americans don't know the signs of suicide, addiction, or mental illness, and I think that's where the clergy certainly have a very important role to play. So we're the group that brought you Mental Health First Aid. I know it's been discussed here with our partners, the states of Maryland and Missouri. We have a youth version, and most importantly, this was not only in the president's budget, but we have bipartisan support on the Hill for legislation, and Senator Harkin's package includes funding for Mental Health First Aid. And I think if there's any questions I can answer, I hope it's going to be about how do you move an agenda? Because that agenda would not have moved, and we wouldn't have people like Mario Rubio on this bill if it were not for our members. So it's about your constituents who who live and work in their areas, in their states or in their districts. That's really where your power lies. No one wants to hear me when I go on the Hill except Schumer and Gillibrand, right? You know, they know I'm from New York immediately. That's where I vote. So that's one thing. The other thing is, so we're going to do all this early identification and detection, and then what? Kaiser Foundation did an interesting poll in February. We talk a lot about stigma. Guess what? There is not much stigma left among young people. Young people are tweeting and writing and blogging about both bipolar disorder, substance use disorders. I just got sent to me a bipolar babe t-shirt by a group of young women who have started this organization. But what people said in this survey is they have no idea where to go for help or how to get help. That is a bigger barrier now, is where do I go? And where do I go if my kid doesn't want to go to treatment, but I'm worried about them? And when you look at the terrible tragedies that took place, it was those families who were also looking for help that couldn't get connected, because in an insurance world, we only bill when we see the identified patient. So that's a whole other discussion. We have something called the Excellence in Mental Health Act, which would create the equivalent of federally qualified health centers that would be partners to those centers, but specialized for adults and children with serious disorders who need the combination of social supports and treatment based on the evidence. So that's another piece of legislation. And for Senator Stabenow, who is from the state of Michigan, and our members obviously have worked this very hard with her, this is the most important bill she has right now. Again, the partner to her is Senator Blunt, a Republican from Missouri. So that's, again, an important thing and something we focus on. The other thing is some of the families and kids you're talking about are involved with 4 or 5 different agencies. They have a pediatrician, they have a case manager from Child Protective, they've got a school officer who's reaching out to troubled families. How in the world can we coordinate this? There aren't enough hours in the day to actually schedule the meeting to sit down and talk about all of this. So the only hope is to do this through technology. And that's a whole other discussion, is how can technology be used as we become more familiar with it and as it becomes a treatment extender as well as a record keeping. Our next big policy initiative is going to be about this idea of early first episode psychosis. So schizophrenia is a low incidence illness, 40,000 cases a year. But when you look at the tragedies, whether you look at Aurora or Tucson or you look at Sandy Hook, it may be that those were young people in the early throes of schizophrenia, quite psychotic. And so what can we do? And we know from research internationally and now here in the United States that there's a package of services that can be helpful to kids and families like that, and that's a big new initiative. So I'm going to stop because I want to hear what all of you have to say, and it's late in the day, and if we don't get you moving, you're all going to be fast asleep. We have a major conference every year, 4,000 people. This year it's here in DC, and I'd love to talk to both of you about some involvement in that. Almost our members in every community across the country are involved in school-based services. Sometimes they're in the school, but I wouldn't swear that the quality of what they're doing is as helpful as it could be. So I look forward to talking to you. Thank you.
So, Linda, I have a question. For those of us who are more sort of on the front lines in terms of delivering mental health interventions and services, how can some of your work inform what we do in terms of, policy initiatives or just what we're doing on the front line versus, how can we kind of communicate what we're seeing on our front lines back to sort of your organization?
That's the most important thing. So recently we had one of the CEOs of a member organization spend 2 weeks with us here in DC. He actually got a foundation to support him. And I think we learned more than he learned. So I come out of the trenches, right? I started as a case aide at Bronx Psychiatric Center. I've been in every single position, and I think having the experience of hands-on is helpful, but oh, so soon we forget. It's easier to sit in an office and come up with policies than actually to implement services. So I think it's a two-way street. We need you, and then we need you to be willing to be politically active as well, to make that phone call, to push that button on our website that connects directly to your congressional delegation. I think those are important things, and we've got to come together around what pieces of legislation we want to move, and then we've got to have corresponding efforts on the state level.
Great, thank you. Lisa?
You can hear me? That's better, thank you. I want to come to the table with my family member hat on too, because I love Barbara Park's cartoon that she showed in the previous panel, where you saw a young man saying, don't I get credit for showing up at school? Well, as a mother of a young man who's been through many, many challenges of behavioral health, trauma experience, et cetera, showing up at community college is humongous, and this is his 7th week of showing up consistently, which is the biggest victory in my life and his life, I think, at this point. So we definitely want to keep that in mind, that that's what it's really about. And when we talk about social marketing and trying to impact behaviors and attitudes of people in the community, we know the best voices they need to hear are the family voices and the youth voices and the adult consumer voices. And so everything we do, and I'll be talking about this more in a second, is what we call youth-guided and family-driven. Those are the voices, whether you talk about on the Hill, in communities, in any kind of marketing effort that you're going to do, it's the youth, families, and consumers that need to be heard first. So, from the federal perspective, we have been implementing the Caring for Every Child's Mental Health campaign, and what I would like to do in the next few minutes is share with you 5 of our strategies and how you can participate in them, and resources that you can access in your own work in your communities. And the first handout that I shared with you, it talks about raising awareness of the early detection of children's mental health. And you'll see that there are 5 strategies listed. Translating the latest behavioral science into communication messages, developing partnerships across disciplines, putting the spotlight on emerging issues, exploring new media and communication platforms, and finally acting as a catalyst for local community action. And these are the areas in which we feel that our federal campaign can work with all of you to make a difference. So I want to share a couple of examples of each of those and resources that you can access. The first one is translating the latest behavioral science into communication messages. This morning, Paulo mentioned National Children's Mental Health Awareness Day. Each May, over 1,100 communities conduct activities with over 136 national organizations. Each year we have a different national theme, and you'll see in your handout that the colorful one, that we've got pictures from a number of the awareness days over the last 8 years. I think one of the ones that's really relevant to our conversation today was one that we did on early childhood mental health. And if you take a look at number 3 on your handout, you may recognize Dr. Brazelton, who was our champion that year, who was an incredible pediatrician, kind of the guru, and I know I was raised thanks to him. A lot of us were. And that was what we did there. We did 2 things. One is that we had, if you look at number 4 on your page, you'll see a very young man with his picture of his feelings. We had a campaign on make your feelings a work of art. Your feelings are a work of art. And we had young children from the local preschool drawing and showing how art therapists, music and dance therapists work with young children to talk about their feelings, which is the first step, really, in the social emotional well-being that our previous panel, in particular Joyce, talked about. We also had a panel of experts across disciplines. We have the opportunity to convene as we're the federal government, and we brought together 2 panels. The first one really looked at social emotional well-being, child development, poverty, and the whole children's mental health for young children. And the second forum looked at the question of what do you do when there's a problem? We're normalizing it. Families always have challenges. What do you do when your young child has problems? And it was a very exciting panel. We had over 300 professionals and graduate students there from different disciplines. So again, we see our role as going across disciplines. I'm just getting over a cold so we can hear that. The second strategy is developing partnerships across disciplines. And I think a great example of that, if you want to turn your page, number 15, I did this instead of slides today. Over 5 years, we got together 18 federal agencies and a number of national organizations, and we put together a guide on early detection and treatment for children and youth for substance abuse and mental health challenges. And the unique things about this guide, which you can get at our website, which is samhsa.gov/children, is that it looked at two things. One, for the first time, the feds got together and talked about what are some guidelines around screening. And a few years ago, you may remember, screening in mental health was a really controversial issue on the Hill. It was a really hot issue. People were challenged about talking about it, and we got together and thought, okay, we need some guidelines to make sure that we're all on the same page about when you do screening to identify problems. And these basic premises that appear in the guide that the feds agreed on are that first, do no harm, obtain informed consent, and we go into detail about working with families and youth to get informed consent, use a scientifically sound screening process, safeguard that screening information, ensure its appropriate use, and finally, link to assessment and treatment services, because we know with any early detection, it's really a crime to raise awareness about the need for it and not offer links to treatment and assessment and treatment, right? I mentioned at the very beginning the importance of partnering with families and youth. And we mean that really equal partnerships, not just involving parents, involving children, but we mean that when we do family-driven care in our systems of care, Marie talked about that earlier today, she's a great example in DC of our system of care that we fund, we mean that the primary decision role in deciding the care and how the care is going to look, it's not the providers driving it, it's the families, both for the individual care of their child as well as being integrated into all the decision-making processes of our systems of care. So they're on all the policy-making boards, they're in all the implementation steps, they help evaluate, they help interview the families to gather data and then interpret that data. In terms of youth, we call youth guided, because developmentally we think it's most appropriate in terms of guiding rather than driving. And that means that youth have the right to be empowered, to be educated, and given a decision-making role in their own lives. And there's a non-for-profit group that really spearheads both of these. The National Federation for Families for Children's Mental Health, if you're not familiar with it, works on the family-driven movement. And Youth Move, which is youth motivating others through voices of experience. Youth Move is the new 501c3 group that is made up of youth who drive the movement across the country. We reach out to create new partnerships. This is a key social marketing strategy. If you take a look at number 12 on your handout, you'll see that for National Children's Mental Health Awareness Day, we began with only 4 national partners, and in the last year we have over 136. And to be a partner in Awareness Day, it's not in name, it really means action. It means something as simple as promoting materials on the website to something as complex as actually conducting an event or a campaign on the local, state, and national level. Now, one of the things that we do is we try to bring different partners who have never worked together. And one great example of that is bringing a for-profit, care.com, which is a group that works with providers, I love it, both elderly, for elder care and for child care, which is a wonderful continuum. When we focused on early childhood for Awareness Day, we brought together care.com with the group 0 to 3, which is a nonprofit group that focuses on early childhood issues. And together they created a website widget which provided tools on early childhood for over 1 million early childhood providers. Another strategy is placing the spotlight on emerging issues. One of the examples of this is a few years ago, we had an Awareness Day national focus specifically on early childhood trauma, because our partners and our communities told us that a lot of folks don't understand that even infants and young children are impacted by trauma, and that they need, in order to be resilient later in life, they need supports throughout life to be able to process that and grow and be resilient. And on our website, samhsa.gov/children, we have a whole list of resources on early childhood trauma. Next year, Linda Rosenberg and the National Council is going to help us on another cutting-edge issue. We're going to be focusing on young adults, 16 through 24 at the National Council meeting. And Linda's generous enough to share a plenary session for our national event, where we'll be bringing in young adults and family members who are peer support professionals. You may know now that there are now certification that Medicaid can reimburse both youth and family peer providers, and we're really going to be focusing that. And our local and state communities will be focusing on how they can leverage that to provide support to social workers, to psychologists, and others in your work. The next strategy is leveraging digital and new media platforms, and one example of that is that on a National Children's Mental Health Awareness Day this year, we conducted a virtual event where we brought in young adults and had them tell their stories about their resilience in education, employment, and their access to healthcare services and in housing. These were young adults, again, 16 to 24. And we did a tweet up. I don't know how many of you know what tweet ups are. That's where you all tweet at the same time and have a conversation during the event. And we had incredible, incredible penetration with Twitter accounts across the country, millions and millions. Finally, the other strategy that I wanted to mention was acting as a catalyst for local community action. Paulo talked a lot about the White House and President Obama's release, when he did the National Mental Health Conference, of the National Dialogue, and all these efforts are part of the National Dialogue. We provide technical assistance to our systems of care, to our partners, to all kinds of organizations, including all the social work associations, on how to do local and state social marketing efforts around increasing awareness and access to children's mental health services and supports. So we can talk about more than discussion, but thank you.
All right, thank you, Lisa. So just one follow-up question. You just mentioned the launch of the National Dialogue on Mental Health by President Obama. What is happening at the local level now as a result of that?
You've heard Marie talk about her dialogue. They've had a number of dialogues across the country. They've had an average of 300 or 400 people at each dialogue, with a large percentage of them being young adults, which I find very exciting, since that follows our principles very strongly. SAMHSA has developed some materials that you can use if you want to do your own conversations. And as Paulo said this morning, and it says on your handout, if you look on the front of it, there is the information brief and toolkit, that's number 2 on your handout, and you can access that by looking at mentalhealth.gov. We also have some specific conversation materials you can access on trauma and resilience, and that's at samhsa.gov/children. And we encourage you to partner across the country to get involved with the dialogues, find out where they're happening, and get involved with them and reach out with the faith community, with social work groups, with art therapy groups, all kinds of different partners, because that's really where the change is going to happen, when people are talking and accessing mental health services and supports.
Great, thank you.
Thank you.
Let's give the panel another hand. So we have about 15, 20 minutes for some questions and answers. So we welcome anyone at this point to address this esteemed panel. And I think they might want you to use a microphone. If you do have a question, there is a mic right here. And then I'm not sure if we're going to have like Twitter or Facebook questions. There were earlier, so be prepared for that.
Hello. My name is Nikita Banks. I'm actually NYU Silver graduate, May 2013. And I'm also a licensed master social worker. My question is, as a recent NYU graduate and a family member of someone who's had mental health issues, I see a part of the stigma piece surrounding mental health has to do with the service providers being proactive. Proactive, I was right. Meaning that a lot of people who are diagnosed with mental illness, it comes from either child welfare involvement, court services, or something that they deem as negative. So I want to know with the initiatives that are happening, what education is being made to promote the services that are proactive. Am I getting this right, wrong? Before that there's a problem, to help prevent any kind of negative services in the environment.
Could I begin with it?
Absolutely.
Sure. In our local communities that we fund, our systems of care, we have developed materials that are specific, that show the data for child welfare, juvenile justice, business, various partners, and show on the national level, and then our local communities marry it with data from the local level, showing the outcomes of why it should make a difference to child welfare workers, to, somebody mentioned probation officers this morning, to police officers. Why should they care about mental health? How is it going to help them in what they need to do? And then our communities reach out and partner with them and do a lot of training. They do trainings for probation officers, for police people, for child welfare workers, and really partner with them, because they know that it's not going to work unless everybody's wrapping themselves, as you heard, around the child, youth, and the family.
And so what was your takeaway from today's event?
Well, I think anytime we're having a conversation about children and adolescents' mental health, the impact of mental health disorders on the family and their communities, et cetera, is very, very important. You know, we don't talk enough about mental health issues in America. Certainly when we talk about them, it's in the context of mass violence or school shootings, where we learn that the perpetrator may have had some untreated mental health issues, and then, you know, we sort of talk about the need to decrease their access to guns, or we think that people who have mental health issues are violent, and that's just not the case. So I think, you know, having a healthy dialogue in a forum like this is very important, so that we begin to communicate messages about what we're doing in our local and national efforts to combat, you know, mental health problems for youth, but also how we need more support, both from federal legislation and policy initiatives, as well as from like-minded and kind-hearted folks like ourselves who are on the front lines doing research, doing practice to try to alleviate, you know, mental health problems for youth and their families. So I think this overall, it's just great to have this conversation and this such rich dialogue in the setting of, you know, Capitol Hill.